I'd like to thank people who supplied me with useful materials and feedback, and the people include Yulia Landa and Susan Gingrich. So I want to underscore the importance of accurate diagnostic assessment of people who are being considered for participation in a first episode psychosis program. Programs are designed specifically to meet the needs of people with a particular set of diagnostic characteristics. The most important thing is to recognize that the specialty nature of comprehensive programs for first episode psychosis are not necessarily effective or beneficial for people who don't have one of the critical diagnoses for eligibility. In addition, we know that when people develop a first episode of psychosis, that providing information to people as well as their families becomes important, and therefore it's important to have as accurate information as possible about the diagnosis. And another thing is that there are limited resources available to treat people experiencing a first episode of psychosis. And so it's important that those resources be used in a way that's as efficient as possible and focuses them on people who have established a psychotic disorder. The typical diagnoses that are included in people receiving a treatment for a comprehensive specialty first episode psychosis program include people with schizophrenia, affective disorder, schizophreniform disorder, NOS, or brief psychotic disorder. That's being quite rare. Now, an indication of how common these different diagnoses are, I'll show you the diagnostic breakdown of two different treatment groups in the ETP study by the NIMH. And this involved the recruitment of 404 clients with a first episode of psychosis, using those exact inclusion criteria, who were then randomized at the level of site. There were 34 sites participating to one different treatment programs: the NAVIGATE program for first episode psychosis, or youth community care. What this shows the percentage of people with the different diagnoses who were admitted to the program. And both sites is actually the majority of people met for schizophrenia. That is, it's a first episode of psychosis. There's a duration of the illness that had lasted for more than 6 months and was accompanied by deterioration in functioning. So despite it being a first episode program, many people have often had illness, schizophrenia or schizoaffective disorder in particular, for significant periods of time. The next largest group is schizoaffective disorder, which is around 25%, 20 to 25% of the sample, having similar chronicity to schizophrenia. Then schizophreniform disorder, in which we do not have that 6 months of chronicity, you can see that's present in around 15, 20% of the sample. Psychotic disorder, that's the green sample, was in an even smaller group, around 10%. The psychotic disorder NOS, which is now unspecified psychotic disorder, DSM-5, that was present in only one person out of over 400, and that's quite rare indeed. So it's helpful to think in terms of what's the common clinical presentation of people experiencing a first episode of psychosis who are being referred for treatment. First is the clear presence or recent history of psychotic symptoms, in particular delusions or hallucinations, although the behavior may also count. You may also get form thought disorder in that the speech may be extremely disorganized, difficult to follow, may include neologisms and so on. That's somewhat rare. It's typical, very significant negative symptoms: apathy, blunted affect, avoidance, anhedonia. It's so common for there to have been a significant deterioration in social functioning, either perform as a student or at work, and care functioning. Usually this deterioration has occurred for at least several months, and sometimes actually over a period of 1 or more years. Your first episode of psychosis, cognitive decline often actually begins several months or even years before the actual onset of psychotic symptoms. So impairment is common in people presenting for a first episode of psychosis treatment. A history of depression is quite common, and in fact, the first mental health symptom that people who eventually develop schizophrenia display before psychotic symptoms is depression. Anxiety is common as well. Depression for a first episode of psychosis, depression is usually not the dominating symptom. It's a very clear feature, such as when a first episode is associated with a suicide attempt. It's possible to identify a period of time in which the person has had psychotic symptoms, but in which mood has not been depressed. Otherwise, if they experience psychotic symptoms only when mood has been either depressed or manic or hypomanic, they would be criteria for a mood disorder and not for schizophrenia spectrum disorder. To talk a little bit about the differential diagnosis of schizophrenia spectrum versus mood disorder. Psychotic symptoms can occur in both mood disorders and schizophrenia spectrum disorders. And you have significantly impaired functioning in both of these disorders. The key distinguishing characteristic is that people who have a mood disorder who have psychotic symptoms only experience those psychotic symptoms during the height of a mood episode, a period of a depressive episode or hypomanic episode. But when that episode is over and their mood is relatively normal, the psychotic symptoms remit. In schizophrenia or schizoaffective disorder, people may have depressive or may have manic or hypomanic episodes. Evidence for persistence or the presence of psychotic symptoms at periods when the person's mood is relatively normal. So it's of psychotic symptoms when people's mood is normal. That is the key distinguishing feature between schizophrenia spectrum and major mood disorders. And it's important to try to rule out people with their mood disorders from first episode psychosis programs, as the tools of their treatment are somewhat different. Psychosis NOS and brief psychotic disorder. For psychosis NOS, how in DSM-5 become unspecified schizophrenia spectrum or other psychosis. In common, it's used to describe cases in which there are psychotic features, but the person does not clearly meet all the diagnostic criteria for a psychotic disorder. As I said, brief psychotic disorder is extremely rare. We saw it in one case out of 404 people in the RAISE ETP study, so I wouldn't worry about that. I think that the detection rate of schizophreniform disorder overall in first episode samples may reflect the fact that there is a long duration of untreated psychosis for many people, which is why we get such high rates of schizophrenia or schizoaffective disorder. A little bit about the differential diagnosis of substance abuse and substance-induced psychosis in people with a first episode of psychosis. First of all, substance use problems are common in people experiencing a first episode of psychosis. 50% of people with a first episode of psychosis have a lifetime history of substance use disorder. Now, I want to also point out that when you're assessing substance use disorder, you can assess both recent or current substance use disorder, and then also assess lifetime substance use disorder. So lifetime refers to it at any point in the person's life. However, we know that people with substance use disorders tend to minimize or delay the effects of substance use, and often report lower levels of current substance use recently than when talking about the past. And there are some reasons to think that the first episode of psychosis, duration of the person's lifetime substance use problems, may actually be more informative about current or recent problems than being just on current or recent problems, with that vulnerability towards underreporting, minimization. These problems are common in first episode psychosis. And actually, the most common substances are alcohol and cannabis, which are used in relatively equal proportions. And of course, combinations are quite common. Psychotic symptoms can be precipitated by substance use. Use, in particular, is associated with an earlier age and onset of first episode psychosis. So, substance abuse and first episode psychosis, of course, can be diagnosed in the same person. That's what we're talking about when we're talking about comorbidity or alcohol or substance use and psychiatric illnesses. However, there is a need to distinguish between substance-induced psychosis from people with a first episode of psychosis and a co-occurring substance use disorder. A substance-induced psychosis is a state in which the psychotic symptoms are induced by the substance use, tend to be persistent to the extent that the substances are used and for typically a limited time period afterwards. In substance-induced psychosis, psychotic symptoms therefore usually remit relatively soon after the substance use stops. Substances are more likely to cause psychotic symptoms. Stimulants are often thought to be the most potent in terms of having potential for increasing or reducing rather psychotic states, paranoia, hallucinations, and things like that. Although cannabis has certainly been associated with psychotic states and other hallucinogens like LSD or PCP may also cause psychotic symptoms. Alcohol is less likely to cause psychotic symptoms, but there are certainly instances of that. The distinguishing whether a person has a substance-induced psychosis versus a co-occurring substance use disorder is to try to examine look for a clear pattern of psychotic symptoms that are closely associated with substance use and in which that pattern of symptoms and impairments changes when there are changes in substance use. So actually you're looking for, and some of this can be done historically, looking back when a person began to use substances, when they began to experience psychotic symptoms, period of time when a person was using more or was using versus was not using, as well as the changes in symptomatology following a psychiatric hospitalization in which a person was using, which there may have been some time to observe the person not using and to evaluate whether there was a relatively quick remission or not of the psychotic symptoms. The main pattern of first episode psychosis is a person to experience a very gradual deterioration in functioning, which sometimes associated with substance use, not necessarily large amounts of substance use. Typically minimal changes in symptoms or functioning when the person stops using substances for a person who has a first episode of psychosis, as opposed to the substance-induced psychosis, in which you tend to see a more rapid return of other mental health functioning and psychosocial functioning, at least in terms of social relationships and the like. In people with a first episode of psychosis often involves relatively minor levels of use. There's abundant evidence that people who have illness, and schizophrenia in particular, do experience problems related to using substances at relatively low levels of substance use. These are the reasons why standard screens for picking up substance use and abuse in the general population are somewhat insensitive to picking up substance use problems in people with schizophrenia and other severe mental illnesses. And that's because of this supersensitivity. It isn't necessarily a clear diagnostic differentiator, but it's one of many different characteristics, clinical characteristics, that tend to be different between people with a first episode of psychosis and primary substance users. The primary substance users often are using much larger quantities at the point when they go into treatment. And therefore, the people with a primary substance use disorder are much more likely to criteria for physical dependence. It's common for people with the first episode of psychosis to criteria for psychological dependence on a substance, which means that they spend a bunch of their time using the substance or trying to procure substance and so on. But the actual amounts used are often not all that high. When you do your very best, it is still often impossible to completely rule out the role of substance use in either precipitating or contributing to a first episode of psychosis. And the primary reason is that because of the relatively short periods of time that people are in the hospital, it's really not possible to observe somebody for a significant enough period of time to evaluate their psychotic symptoms, for example, are completely substance-induced. And you may be able to observe the person living in the community without that. Or you often have to make judgments as to the likelihood of the person having a primary first episode of psychosis and a co-substance use problem, or whether the problems are really better accounted for by considering the person as having an addiction and a substance-induced psychotic disorder. That's where we recommend using the walks like a duck rule. If it walks like a duck and talks like a duck, okay, let's treat it as a duck. And the idea here is that there's a significant hazard or a significant cost to be paid by not providing comprehensive first episode psychosis treatment to somebody who really needs it. And therefore, if the person in every way, shape, or form appears to have a first episode of psychosis, despite a complex pattern of substance use, the recommendation is to treat them as though they do have or are experiencing a first episode of psychosis and admit them to the program. Now, it's possible that over time, additional information will end up leading to change the diagnosis, in which case the person may end up being discharged and referred elsewhere for services. But there are many reasons why people may end up leaving a first episode psychosis program. Changes in diagnosis are one of them. But we encourage people to lean towards over-inclusiveness after making a good effort to distinguish substance-induced psychosis from co-occurring substance use problem. I'm not sure if I breezed over it or not, but I think I have a number of recommendations for improving diagnostic reliability, but that's not specific to substance abuse. I'll go on. Next differential diagnosis is autism. Possible for people with autism to all develop a schizophrenia spectrum disorder, although to my knowledge it's relatively rare. Autism is a developmental disorder with a pattern of social and learning difficulties typically dating back to childhood. Although people with schizophrenia may have had certain challenges, difficulty learning and so on in childhood, typically did not meet criteria for a developmental disorder. The infant in autism is relatively stable, although there's some evidence that it gradually improves over time. The onset of a first episode of psychosis tends to occur in late adolescence or early adulthood, and is marked by clear deterioration in functioning, although it may take place over several months or even a year or two. There's clear deterioration in functioning that you not ordinarily find in people with autism. Social problems are common in both disorders. Psychotic symptoms, voices, delusions, are quite rare in autism. Differential diagnosis of comorbid PTSD is a primary diagnosis of PTSD, that is, post-traumatic stress disorder. Sleep trauma is common in people who develop a severe mental illness for a number of reasons. The experience of traumatic events in childhood increases the risk of people developing a wide range of mental illnesses, including schizophrenia. In fact, we know that people with a severe mental illness are much more likely to have post-traumatic stress disorder, which is the psychiatric disorder really most associated with exposure to trauma and defined in terms of the consequences of exposure. Overall population, the post-traumatic stress disorder is around 10%. A little bit for women, around 2%. A little more for men, around 7 or 8%. And these lifetime rates. At any one point in time, the rates of post-traumatic stress disorder in the population are around 3 or 4%. Now, severe mental illness, the rate of PTSD jumps to 25 to 50%, looking at current or recent traumatic stress disorder over the past month. So, huge increase compared to the general population. Now, the rate of increase is actually the same across different diagnostic groups. The high rate of post-traumatic stress disorder tends to be people with depression and also borderline personality disorder. There are a little bit over 50% of post-traumatic stress disorder. And bipolar disorder, around 40%. And in schizoaffective disorder, slightly lower, 25 to 35%. But it's still common than the general population. Among a first episode of psychosis, we had information, but that information suggests that about 20% of people experiencing a first episode of psychosis also have post-traumatic stress disorder. So we know that post-traumatic stress disorder is a relatively common co-occurring disorder in people with the first episode of psychosis. And both of the disorders can be diagnosed, and it would probably be helpful to include assessment of post-traumatic stress disorder in any routine assessment that's done to determine eligibility for a first episode psychosis program. So let's look at the assessment of PTSD. Some issues about the differential diagnosis of PTSD versus first episode psychosis. Oh, sorry, my phone. First of all, you can screen for post-traumatic stress disorder and trauma exposure using widely available and relatively brief screening instruments. There are trauma screens that have about 15 questions designed to assess lifetime exposure to traumatic experiences. And then there are self-report screens also that involve having the person go through and identify which symptoms of post-traumatic stress disorder they have. The current most widely used self-report screening measure of PTSD is called the PCL-5, which stands for the PTSD checklist. Last version being modified for the DSM-5. Now, already showing high rates of trauma in people with severe mental illness. We don't need to spend much time on it, but the red refers to childhood exposure. The green refers to exposure in adulthood. And this of exposure here are sexual assault or abuse, physical assault or abuse, or witnessing the assault or death of another person. Because of high rates for both men and women. It summarizes around 10 or 12 studies looking at rates of post-traumatic stress disorder in clients with a severe mental illness. And one of the studies that has a somewhat lower rate, Neria study, it's actually, I think, the seventh bar from the left, that was completely done on a first episode psychosis population, a pretty large study, over 200 people in it. But what is that the rates of these studies of PTSD in people with severe mental illness range between 25 and 50%. Let's get into issues of differential diagnosis versus comorbid diagnosis. We talked trauma is common. And, so I'm going to go on to the next one. So let's talk about the symptoms of post-traumatic stress disorder. There are 4 symptoms used in the DSM-5 to define PTSD. The symptoms are experienced with respect to a particular traumatic event. Now, it's common for people to have multiple traumatic events of a kind, such as childhood sexual abuse or childhood physical abuse, and they may have more than memory related to it. But the essence of an assessment of PTSD is that what you're trying to do is to link particular psychological symptoms to a specific traumatic experience or a set number of traumatic experiences of a related theme. The first type of symptom is intrusion symptoms. And the most intrusion symptoms or re-experiencing symptoms refer to symptoms in which the person has some aspect of the trauma returned to them. The most common way in which it occurs is intrusive memories of a traumatic experience. The memory pops into the person's head, and they have a very high level of distress when that happens, and often try to get that memory out of their head. Experienced as a memory, the person is aware that it's a memory. It happens unexpectedly, which makes it intrusive. Something related but a little bit different is a flashback, where a person momentarily has the experience as though they are they're in that event, experiencing the traumatic event again. Flashbacks occur very briefly and only last for a few seconds. It's possible to have more extended flashbacks or dissociative states, but tend to occur relatively infrequently in people either with PTSD or people with psychotic symptoms, in my experience. The symptom is nightmares, and nightmares are thematically related to a traumatic experience, but they're not a simple repetition of a particular event that was experienced. People may also have distress when they're exposed to cues that prompt memories of the traumatic event. The second cluster of symptoms is avoidance symptoms, and this is avoidance of trauma-related stimuli. So this people avoid memories, situations, people, anything that may remind them of the traumatic event becomes avoided. This can include close relationships with people. It can include sexual activity. It can include going out and meeting people. Somebody who's been in a car accident may avoid driving, so on and so forth. Cluster of symptoms is overarousal or hyperarousal. And this is characterized by people who have a hypervigilance, this increased vigilance on scanning the environment, continually on the lookout for danger. They have a lot of difficulty sleeping. They have a lot of autonomic arousal, increased heart rate, perspiration, great muscular tension. The associated feature of this is that they are often more prone to anger outbursts as well. And the symptom cluster of PTSD. This is a cluster that was added in the DSM-5, but I have to say, having done years of work with PTSD, I had never seen people who didn't have the symptom cluster. They had the first three. It has to do with negative alterations in cognitions or mood. So, for example, the person may have forgotten certain parts of the event. People often have very negative beliefs about themselves, where they blame themselves for things or blame themselves for being weak. They often have beliefs about other people not being trustworthy based on their traumatic experiences. They may have more globalized beliefs about the overall world being unsafe or cruel or in a place. Often have difficulties with mood. They may have a significant depression. They may have a guilt or feelings of shame, strong feelings of anger, having been wronged. They may have high levels of free-floating anxiety. So all the common symptoms of post-traumatic stress disorder. Post-traumatic stress disorder is kind of like substance abuse in that comorbidity is more the norm than the exception, which is another saying it's very common for people with post-traumatic stress disorder to have a wide range of other both symptoms and disorders. The most common disorder associated with post-traumatic stress disorder is depression. Half the people who have post-traumatic stress disorder meet criteria for major depression. In addition, many people have a persistent guilt feelings. Suicidality and self-injurious behavior are common. Who are engaging in self-injurious behavior, not suicidal behavior, then they have PTSD. Sometimes the self-injurious behavior is a way of escaping these re-experiencing symptoms. They're refocusing on something. They're refocusing on the pain of cutting themselves rather than upsetting memory of a traumatic event. These problems are relatively common in people with PTSD. And psychotic symptoms, although this is not recognized in the DSM, there's a very good research literature showing that you get mild levels of psychotic symptoms such as hallucinations and visions, and you get some mild elevation of bizarre behavior in people who have post-traumatic stress disorder. Those psychotic symptoms can't be attributed to a disorder or another psychotic disorder. So it's possible to have these mild psychotic symptoms in addition to the PTSD symptoms, and it tends to occur in people with more severe PTSD symptoms. is that up until this point, I've been talking about post-traumatic stress disorder related to the kinds of traumatic events that's commonly reported in the general population as contributing to PTSD. And those include events in which the person experiences either directly or observes an event which presents a grave threat to their life, livelihood, bodily health of themselves or others, such as a physical assault, a sexual assault, being in a natural disaster, being in a major accident, experiencing the sudden and unexpected death of a loved one. Those are the most common traumatic events that lead to post-traumatic stress disorder. It's been observed that the experience of psychotic symptoms for the first time, hearing voices, believe people are out to hurt you, this experiences may be traumatic in their own right, and will be traumatic experience of developing a mental illness and being told that you have a mental illness. And then there are also traumatic experiences related to treatment experiences. So, for example, an involuntary hospitalization, being in seclusion or restraints, being forced to take medication. These coercive treatment practices may also be experienced by some people as traumatic. And these kind of experiences are broadly subsumed under the rubric of the trauma of psychosis. It's been observed, and these observations actually go all the way back to the 1980s, the ECK group in Australia that really started all of the concerted work focusing on the treatment of people with the first episode of psychosis, that the trauma of psychosis itself could lead to PTSD-like symptoms and even a PTSD-like syndrome that could have important implications. We've done a number of studies on PTSD related to psychosis, related to either the trauma of psychotic symptoms or coercive treatment experiences. What we've done is evaluated people who have PTSD symptoms related to the psychotic experiences and evaluated their levels of distress and depression as well as their functioning. You tend to see is that the people who have PTSD symptoms related to the experience of psychotic symptoms or to coercive treatment experiences, those individuals tend to report high levels of distress overall, in other words, more severe anxiety, depression. That's not what's depicted here, by the way. And they also report more problems functioning, and that is what's depicted here. This is a study of 38 people with the first episode of psychosis. We did to identify people who had PTSD symptoms related to the experience of psychosis or coercive treatment experiences. Between the two of them, the psychotic symptoms themselves are a little bit more likely to lead to PTSD than the treatment experiences. Of course, the treatment experiences can be significant as well. But what we see here is that the people who have PTSD related to their psychotic experience have more problems in functioning, because these are negative effects. A higher score is a negative effect in school and in terms of household functioning. So for that reason, it may be important to pay attention to PTSD, but to also be open to exploring PTSD related to the experience of psychotic symptoms. Okay, let's go back now to the issue of the differential diagnosis of comorbid PTSD versus PTSD as a sole diagnosis. So, re-experiencing symptoms in post-traumatic stress disorder, by far the most common presentation is as intrusive memories that are thoughts. The memory pops into a person's head, they observe it as a memory, and it's distinct because it's a memory of a traumatic event. Flashbacks in which a person momentarily thinks that they're re-experiencing the trauma are much less common. Usually when people say they have flashbacks, actually what they mean is intrusive memories, and you can clarify that by explaining it or going into the nature of the experience. But by definition, a re-experiencing symptom needs to be linked to a traumatic event. Section between re-experiencing symptoms and hallucinations and so on, the most important first thing is to establish that the symptom related to the experience of a specific traumatic event. It's also worth noting that re-experiencing symptoms can be present as hallucinations. So for the person heard the voice of somebody talking to them, and this was a person who had previously attacked them, that would be read as a hallucination if it were heard as a distinct voice, like through the years, although a distinct voice even inside somebody's head can be rated as a hallucination as well. In case the symptom could be rated as both a hallucination and a re-experiencing symptom. I have to say it's less common, but it's not. I wouldn't say it's uncommon. In post-traumatic stress disorder, avoidance symptoms are also clearly related to specific traumatic events, and generally speaking, the person can help make that connection. They're avoiding people or a place because it reminds them of a particular event. In contrast, in people with the first episode of psychosis, but who don't necessarily have PTSD, you tend to have a much broader social avoidance, where what you're really doing is a reduced social motivation to engage with other people rather than avoidance of something in particular. Now, helpful to note that sometimes you get delusional elaborations on trauma-related themes in people who have post-traumatic stress disorder and a psychotic disorder. For example, a person may have been sexually assaulted, but then they also develop a delusion about a ring of people out to get them or out to sexually use them or something like that, in which there may be no such or organization at work, in which case the person may still meet criteria for PTSD. They have the PTSD symptoms, but they also meet criteria for a first episode of psychosis if the delusions are significant enough, because there's this delusional elaboration. Actually, a great deal of work underway in cognitive behavior therapy for psychosis in terms of trying to understand the experience of different life events that give rise to different psychotic symptoms. And lots of evidence that different life events, in fact, play a role in shaping the nature of psychotic symptoms that people experience, including hallucinations and delusions. So for people who have been bullied are likely to develop delusions of paranoid delusions. The issue in terms of determining whether the person has PTSD has to do with evaluating whether in particular, whether the avoidance symptoms and whether the re-experiencing symptoms link to specific memories of specific events rather than more broadly based negative experiences. I leave it at that. People may have other questions, and then we can bring them up. I'm going to say something that may be a little bit surprising, but when you start approaching the differential diagnosis, if you do the trauma history, you identify the most upsetting trauma, and then you evaluate the presence of the PTSD symptoms, it's usually relatively clear. 90% of the time, you can tell if the symptom is related to the event or not. And so the challenge in terms of distinguishing between psychotic symptoms and flashbacks, and the challenge between distinguishing social avoidance or trauma-related avoidance from negative symptoms has to be less difficult in practice than you might think it is in theory. So to get a little bit, if the person has PTSD and all of the psychotic symptoms are related to the traumatic event, you might have a diagnosis of PTSD. You probably meet criteria for an episode of psychosis. If everything is related to the traumatic event, you might consider holding on that and see if you could find good, high-quality treatment for the post-traumatic stress disorder. If the rinsing symptoms are also hallucinations, and the appear as voices or visions directly related to the traumatic event, that's a relatively uncommon thing. So I think you have to worry about that. And then delusional elaboration on trauma-related themes is possible. I'd say unless everything is trauma-related, if the symptoms match up with PTSD, the person merits a diagnosis of PTSD. As long as they have significant psychotic symptoms, they may end up earning a diagnosis for the first episode of psychosis as well. A little bit about duration of untreated psychosis. The psychosis is defined as the period of time between when a person first begins to experience psychotic symptoms and the point at which they then receive treatment for those psychotic symptoms. Sometimes it's defined very specifically in terms of receipt of antipsychotic medications. We talked about this in the last webinar. The longer a person's duration of untreated psychosis, the more difficult it is to clinically stabilize their symptoms, and all the worse is their overall prognosis. It's possible that people who have more gradual onset of their psychosis, because the onset is more gradual, it's also more difficult to identify them as having a psychotic episode, and that gradual onset contributes to a longer duration of untreated psychosis. The reason it's important is that we've known that people experience an insidious onset of their psychosis, as opposed to a more rapid onset, to have a worse prognosis. So it's possible that some of the association between duration of untreated psychosis and worse prognosis really isn't the duration of untreated psychosis per se, but is more related to the amount of time it took for the person to first begin to experience psychotic symptoms. In any longer a person is psychotic before getting treatment, the potential is for to themselves as well as harm to other people, as we know from various mass violence events, but we also know from suicide that early intervention programs are effective at preventing suicides of people with the first episode of psychosis. And earlier intervention is important in terms of reducing suffering and in terms of trying to get people back on a personal life trajectory towards recovery. So that's the reason why there is a strong push toward strategies for reducing the duration of untreated psychosis. And part of the way of doing that, or an essential thing if you're going to do it, is to have effective comprehensive first episode psychosis programs to treat those individuals in. Generally, a duration of untreated psychosis less than 6 months is considered on the relatively shorter period of time, and more than 6 months is considered on the relatively longer period of time. In the study that we just did, the RAISE Early Treatment Program study, RAISE ETP, study that I referred to earlier with 404 people, its duration of untreated psychosis was actually a little bit over a year. So that's a very long period of time. Comprehensive first episode psychosis programs usually do not exclude people with duration of untreated psychosis. Because duration of untreated psychosis is of such interest, there are a number of different ways of measuring it, and it's common for first episode programs to routinely measure duration of untreated psychosis. This is a depiction of the clinical course of the onset and course of schizophrenia. And you can see the second period is something I'm going to get into in a moment, but the prodromal period. The pro period is that period in which the person begins to experience reductions, a deterioration in psychosocial functioning, and they begin to experience a number of different mental symptoms, including transient psychotic symptoms. And that's a period that is also of great interest because people have begun experimenting with interventions to see if you can identify people who are in the prodrome who are at risk for developing a full-blown psychosis and schizophrenia, and we can intervene at that period and prevent a full-blown episode of psychosis from developing. Schizophrenia prodrome is defined by the following symptoms and signs. People are experiencing increased difficulty at school or work. Age range for this would typically be teenage years, later teenage years, or early adulthood, where from, say, 15 to 25, although it's possible to have a prodrome and a first episode of psychosis at age 30 or 35. Second factor would be withdrawal from friends and family. Third is difficulty concentrating or thinking clearly, suspiciousness, mistrust of others. Sometimes people have variations in their sensory experiences in terms of the way things look or sound. They have some odd thinking behavior. Their mood may be more labile, prone to emotional outbursts. They may have problems in their personal hygiene. So, measures, both self-report measures for screening and then structured interview measures for identifying the prodromal syndromes or the prodromal state. There's no diagnosis, no accepted diagnostic category for the prodrome. One is called the structured interview for prodromal symptoms. The other one is comprehensive assessment of at-risk mental health states. And there are syndromes within the prodrome. Include attenuated positive symptom syndrome. It means it's characterized by these mild psychotic symptoms. Brief intermittent psychotic syndrome, so there's been occasional psychotic symptoms that then go away. Or other syndrome where there's a genetic vulnerability, family member, plus some deterioration in functioning. And those are separate prodromal syndromes, but all considered part of the prodrome. And the question becomes, okay, are you assessing somebody in the prodrome or are you assessing somebody with a first episode of psychosis? So that's a really critical distinction. The thing is that antipsychotics are recommended as a first-line treatment along with psychosocial treatments for people experiencing a first episode of psychosis, but not generally recommended for people in the prodromal state. And one of the reasons for this is that the rates of conversion, in other words, the rate of people who have the prodrome who then develop a first episode of psychosis varies quite a bit. Usually the highest of the rates is around 50%, but varies from study to study, with lower rates being 30, 20%, and so on. And so the difficulty is that you don't want to expose somebody to antipsychotic medications if there isn't a really good chance of them developing a psychotic episode, because antipsychotic medications do have serious side effects. And so that's the critical reason why an accurate differential diagnosis between the prodrome and the first episode of psychosis is important. Now, I say that many other interventions that are done in first episode of psychosis will be helpful to people in the prodrome, and there's some programs that set out to treat people in the prodrome as well as first episode. But differential diagnosis is critical to make even in those programs, because a determination needs to be made about whether to give the person antipsychotic medication. The primary distinction is the presence of clear psychotic symptoms in first episode psychosis compared to more transient psychosis-like symptoms in the prodrome. Difficulties concentrating thinking, social difficulties, and things like that tend to be present in both of the disorders. Overall impairment in psychosocial functioning tends to be much worse in people experiencing a first episode of psychosis. So the distinguishing characteristics really are the prominence of the psychotic symptoms and the overall level of severity of psychosocial impairment. And I'll end in the second on diagnostic accuracy. You do, of course, seek to rule out medical factors that may have led to particular symptoms. Reading instruments may be useful in detecting first episode of psychosis in some settings. If you have access to settings in which people come in with psychiatric problems, you could actually identify people with first episode of psychosis who might not otherwise be identified through routine screening picks up more people than any other method, really. Trying to develop a timeline of the onset of different problems and symptoms can help in terms of a diagnostic accuracy. Structured clinical interview with standard questions and prompts may also improve reliability. There's many such interviews, such as the SCID. The ability of getting reports from collaterals or informants, such as family members, other treatment providers, is very important for the first episode of psychosis. Interestingly, we know that when people have been in the mental health system for a few years, that psychiatric diagnoses are very, very accurate. And one of the reasons is that you have much, much more information on the person from different health providers. When coming in for a first episode of psychosis, all you have really is what the client says and any other information you can get. And an incredibly useful sort of information is the reports of family members who know the person better. They've been able to see the person in their home. These reports, as well as the reports of other treatment providers, can be used as a basis for a structured clinical interview to determine the presence and absence of particular symptoms. So probably the single most important thing to do to complement an interview, and preferably a structured clinical interview, is to be able to reach out and to tap and to get information from informants, from people who know the person well and maybe have known the person over a period of time. And then, of course, review of medical records. I'm not these in detail, and I've provided a handout with different resources. This has to do with screening instruments, and this the slide reviews different clinical interviews. This involves methods for measuring the duration of untreated psychosis. And this last set of slides just goes into what comprehensive assessment of the first episode of psychosis would entail. And here what we're doing is we're going beyond identifying eligibility. Here what we're doing is we're trying to identify what the person's needs in order to inform treatment. So work functioning, social functioning, motivation, psychology aspects, and so on. One assessment instrument of particular interest, which is used in a lot of first episode psychosis studies, is the quality of life scale. This is different than quality of life interview. It's not based on subjective ratings. It's a semi-structured interview with a person, and it yields information about the person's psychosocial functioning in terms of relationships, as well as functioning in work and school. And then there's a very interesting part of it. It's called Psychic Foundations, but it gets into issues related to the person's sense of purpose, their curiosity, motivation, anhedonia, a lot of things related to recovery. And so I wanted to have a kind of a structured, functionally oriented interview to help you in treatment planning. The quality of life scale could help with that. Managed substance use, psychology in there twice, health, involvement, self-management, and symptoms. And I think I'm going to stop right here, just to leave some time for questions. Let me briefly say what this is about. We know suicide is a significant risk factor in people with schizophrenia, and risk tends to be greater in people at a younger age. And therefore, it's important to be mindful of it, and given any evidence of suicidality or history, to do a careful assessment. The most important indication of suicide risk is previous suicide behavior. And there is evidence of previous suicidal behavior, or when the person is having thought of suicide or having thought about being better off dead, those should trigger a more detailed clinical assessment aimed at evaluating specific plans, methods, intent, things like that, and safety purposes. Also, immediate referral for CBT, CBT for psychosis, and consideration of medication changes, including clozapine, should be on the table. Hallucinations refer to when a person has hallucinations that tell them, that tell the person to do things. And command hallucinations are linked to aggression as well as self-injury behavior. It's worth noting that the vast majority of people who have command hallucinations don't follow those hallucinations, but it is a risk factor in terms of following it. So when hallucinations are identified, it should be followed up with a more detailed assessment aimed at evaluating delusional beliefs, the sense of control, sense of self-control over one's own behavior, as well as, of course, review of past behavior that may be indicative. Okay, a little bit, but I'm happy to take a few questions.
Kim, we have one question here. Is it beneficial to explore other forms of trauma, meaning subclinical areas or non-diagnosable forms of trauma? Looking at the 2013 study from O'Hare, differences in trauma and post-traumatic stress symptoms in clients with schizophrenia spectrum and major mood disorders highlighted, looking at stressful events outside of trauma.
Question. How much more detail to go into in terms of a trauma assessment? I would say at the initial assessment, my advice would be to evaluate trauma experience or trauma exposure, including both regular time events, assaults, and things like that, as well as the experience of psychotic symptoms and treatment experiences, and also to look at traumatic reactions to those, because we know that they're relatively common, and also have effective treatment approaches for helping people overcome them. But it would be to not get into issues of subclinical trauma or other types of trauma, primarily because we have some reason to expect that post-traumatic stress symptoms or negative psychological reactions to trauma are going to be at a higher rate or increased during the first episode of psychosis, high rates of depression associated with first episode of psychosis. And we know in general that the severity of PTSD symptoms and depression are closely linked to one another. And so it's common for people to have some post-traumatic stress disorder or stress disorder symptoms that resolve or improve with just good overall treatment as the person's depression decreases. One inclination would be to wait until the person is more stabilized, identify, figure out what the most critical treatment needs are, and attend to those, and to consider returning to a more in-depth assessment of trauma if certain challenges persist.
Great. Well, I think that was the only question we had. Several people said very much for an excellent overview and instructional presentation, and I'd like to thank you as well, Dr. Muser. I'd like to thank everyone else for joining today. You will receive your email with the link to your evaluation and post-test within about an hour, and there will be some instruction in there for a few people had technical issues connecting today, so we'll try to solve that next week. Anything to add, Dr. Muser?
I'd like to thank everybody for attending.
Thank you as well, and I hope everyone has a great weekend.